Dear healthcare professionals, in this video I am going to share with you fourth case in the series on diagnosis. The series of interesting, uncommon and challenging cases which I came across during my clinical practice while working in critical care. Videos are helpful for all healthcare professionals. I will share a real case that was presented to our hospital's emergency. In this case, the simple mistake of not identifying underlying cause would have led to continuation of initial wrong treatment, therefore possibility of poorer outcome and likely mortality. I will walk through real scenarios so you can connect this story with real-life clinical situations. So, let's embark on this story of making the uncommon, interesting, and challenging diagnosis and how it impacted the patient's management and the outcome. Let's begin with our case. A 28-year-old man presented to hospital emergency in unconscious state. According to bystander, he was well few hours back, and when the next time he was seen, he was completely unresponsive. There was no other associated significant history. On presentation to emergency department, he was unresponsive with stable vitals without any focal neurological signs. He was seen initially by emergency physician and later by neurophysician. After initial evaluation, neurophysician made the differential diagnosis of stroke, status epilepticus, and meningoencephalitis. CT scan brain was done that did not reveal anything significant. He was started on ceftriaxone, acyclovir and levetiracetam and was shifted to intensive care unit. There was no past history of diabetes, hypertension, heart disease, stroke, seizure or any other significant medical illness. Case was seen by ICU team led by me next day morning. Based on the initial description, we requested more information from bystander. As bystander was not available during that time, we made a telephonic call to him requesting to visit us as soon as possible. We gathered more information from him as patient was still unresponsive. According to him, he was well till 1 p.m. as he had lunch. Thereafter, patient told his friend that he is going to have nap. After around 45 minutes, patient's friend found him in the unconscious state in the car where he was having his nap. Thereafter they activated ambulance services and brought him to the hospital. This history led us to think entirely differently than what was already going on. Can you make any guess what exactly happened to this patient or what you would like to do next? ICU team immediately checked patient's arterial blood gas analysis, which also has co-oximeter value within a single report. Usually, ICU physicians are trained to look pH, partial pressure of oxygen and carbon dioxide, electrolyte, hemoglobin and lactate value in ABG. Many a times blood gas analyzer does not report co-oximeter value or physicians skip that part. In our patient, nobody looked at co-oximeter value since nobody suspected it, and physicians are usually not used to have a look on co-oximeter values. As the common saying goes, what the mind does not know, the eyes do not see. Co-oximetry measure the levels of different forms of hemoglobin in a blood sample, including oxyhemoglobin, carboxyhemoglobin, and methemoglobin. On our evaluation, his carboxyhemoglobin value was very high at 37% in the emergency department. Now, diagnosis was clear to us, and it led to change in the treatment and so the outcome of patient. The patient stayed with us for more than a week in ICU, but at the time of discharge, he was completely recovered, at least in the short term, since carbon monoxide toxicity also has delayed effects. So, what led us to think about checking co-oximeter value? It was patient's history of sleeping in the car with engine and AC on. It is possible to develop carbon monoxide toxicity while in a car with the engine and AC on, even with the windows cracked open. Carbon monoxide is a colorless, odorless gas produced by burning fuel. If there's a leak in the exhaust system or if the car is in a poorly ventilated area, CO can accumulate inside the vehicle and lead to poisoning, especially when the AC is on recirculate. So, what could have been possible if we continue with the treatment initiated at the time of admission in ICU without identifying underlying etiology? Not knowing the underlying cause could have led to patient's death as his toxicity was severe. Carboxyhemoglobin level more than 30% is considered as severe poisoning. We were able to provide targeted treatment once the diagnosis became apparent to us. By establishing the underlying cause of unconsciousness, hence, by establishing the correct diagnosis, we were able to prevent likely mortality. So, Diagnosis of this patient was not stroke, meningoencephalitis, or status epilepticus but carbon monoxide poisoning. Coma was a finding and unconsciousness was a presentation. So, establishing an underlying diagnosis is an essential component of treating patients. Healthcare professionals should be cognizant of the difference between diagnosis, findings, and presentation. Misdiagnosis or no diagnosis can lead to incorrect treatment, complications, and potential morbidity and mortality. Hope this was an interesting case. If you like this information, please subscribe to this channel for more interesting and challenging diagnosis.